Every year, an estimated 15 million babies are born premature, and Kenya accounts for 183,000 of these babies. In this episode of Health Watch, we tell you why it's important to prevent complications and death among these children despite the rising numbers. It is the hope of every expectant woman to give birth to a healthy baby. However, some babies come too soon before the estimated due date, a condition doctors refer to as premature birth. These babies often require special medical care in a newborn intensive care unit to help avert health complications that the condition predisposes them to, or even death.
There are many causes of premature birth. The commonest cause is actually infections in the mom, and this could be infections like urinary tract infections or malaria or low mom who has low HB. Increasingly, we are seeing many babies being born premature because of hypertension in pregnancy in the mom, and this hypertension in pregnancy, we call it preeclampsia.
Anita Nzau's baby was born premature a year ago at 25 weeks. Like many parents, the thought of having her baby before term was unsettling.
At first, when I saw her, I remember it took me like 24 hours to go see her in the NICU. So it was terrifying. And when I saw her, I was like, will this baby make it? She was so tiny. She was 740 grams. Huh? So she was so tiny, I didn't know what to do.
Her pregnancy journey was not easy either.
All through the pregnancy, I had to be on complete bed rest. I had what is called the cervical incompetence. So I had to go to theater, they fix a McDonald's stitch. Then at around 23 weeks, my membranes ruptured. So I had to be hospitalized for 2 weeks until it got to a time where the amniotic fluid had kind of completely drained. So they had to deliver the baby. So at that time I was given 2 options, either deliver normally or we go do the C-section. So according to the advice that I was given by the doctor, I opted to do the cesarean section.
Globally, prematurity is the leading cause of death in children under the age of 5. Dr. Lango also reveals that the number of children being born premature is often on the rise. This he attributes to some factors.
With increasing number of assisted conception, we're getting more and more multiple gestation, meaning pregnancies with more than one baby. And the more the babies are in the womb, the more crowded the place is, and that increases the risk of needing to come out early before time. So right now, that has impacted on the rate of premature birth in our community here in Nairobi.
Experts say 3/4 of these deaths could be prevented.
Our facility, as you've seen it, it's quite a large facility, very, very well equipped with state-of-the-art equipment. We have a 12-bed capacity NICU, that is neonatal intensive care unit, where we can ventilate up to 12 babies at any one time. We also have an HDU, neonatal high care unit, that has 15-bed capacity, and many times we have even up to 20 babies in the unit. So for us, we have a very strong team that's dedicated to the care of these preterm babies. We plan beforehand. We inform our colleagues, the nurses. We inform our team in the NICU, and we all come together to plan the exact time that this is going to happen. We prepare the drugs that we need to give, the machines that need to be given beforehand, and at any one time when we get a preterm baby, it ends up being a seamless transition from the womb to the unit. And this has helped us get very, very good outcomes. We rarely have mortalities in this unit, despite the extreme cases that we get every time.
We receive all sorts of babies, premature, extreme premature, from 25 to 28 weeks, and even beyond. When they come here, there are different interventions that we give. depending on the presentation of the baby. There are those that come, we have to give surfactant. If they are very distressed and they need to be supported, we give them surfactant, and then we can intubate them, put them on the ventilator. And as they stabilize, we wean off the ventilator and we put them on what we call simple CPAP, and eventually we go to breaded oxygen. Somehow we don't give 100% oxygen in our unit, but we give breaded, and which is warmed. We don't give cold air to the babies. And until they are ready for discharge, we discharge them to the NHDU. Most of the babies here will stay for 2 to 3 days, but not limited. A few would stay even for a week or 2, depending on the severity of their condition. There are other category of babies we receive in this NICU. The babies who have had hypoxia, could be in utero or in delivery. And when they come here, we do what we call cooling. This is a system where we put them on a machine to make them reduce their metabolic rate to a point that the activities in their brain are totally reduced. And we do this for 72 hours, and then we start warming. And this one, I think we are the only center in the region that is doing this. So we cool our babies, and eventually their outcomes are very good. They are reducing the number of babies with cerebral palsy. And we have seen so many of them who we have cooled. The outcomes are reasonably very good. So it is a good thing that we are doing. And while we are doing the cooling, we also measure and monitor their brain activity. We have a machine that we call CFM EEG machine. We do monitoring of the brain activity at this time. And we can tell whether these babies are having conversions or not. This is done concurrently with the cooling. It's also a machine of its own, and I don't think there is any other center that is doing in East and Central Africa. Probably South Africa, probably they are doing that. But we are the leading institution with that. While our babies are here, despite the surfactant, there are other issues, other cares we give. Despite administering surfactant, we also give some drugs like caffeine, which help the baby, so we don't have our babies going into apneic attacks frequently. They are given the caffeine either intravenously or per mouth, and we have seen great improvement with such kind of medication. We also give them, depending on how they are presenting, if they are having infections, we can give them antibiotics. And where they are not having infection, we don't give antibiotic routinely. We give where we are having the infections confirmed. Routinely, we don't give unless otherwise preventive extreme prematurities. We can give the baseline of the antibiotics.
In a bid to help preterm babies thrive, experts say feasibility cost-effective care, such as Kangaroo mother care, among other interventions, go a long way in helping reduce hospital stay and improve the quality of health of the child.
Not all interventions are costly, but it's good to mention that neonatology is technology-intensive practice. Okay, beyond a certain level of skill, you need the equipment, because these babies need to be put in thermoneutral environment. You need to be at particular temperatures. You need to be able to push oxygen into their lungs. You need to be able to open up their lungs. You need to be able to give drugs to the lungs to mature them. And these things, it's technology. It's going to cost money. But back to your question, we do have Kangaroo mother care. That is a very effective technique to help mothers bond with their babies. It reduces the rate of infections for the neonates, and it gives them the warmth that they need. So they tend to grow better. Moms tend to have more milk because of that kind of care, and they feel more involved. So the bonding helps us very well in terms of growth and early discharge for these neonates.
All our babies premature, once they are stable off the ventilator, we all start them on Kangaroo mother care. And this is a practice where the baby is put skin to skin with the mother. And we encourage all our mothers to do Kangaroo care because it has a lot of benefits. Number one, it helps them in bonding Remember, this baby has been separated, and we are trying to reduce the separation of the baby from the mother. So we allow them to sit in the unit, even if the babies are on oxygen or what. We allow them to sit in the unit, do kangaroo. We put the baby in an upright position on between the breast, and we allow them to do as much as they can. If a mother can do even 6-8 hours, we allow them to do the kangaroo mother care, because we have known of its benefits to the baby, to the mother, to the institution, and to the nation as well. When we do it to the mother, there is boarding. There are chances of reduced hospital stay, so the cost is also reduced. For the baby will not stay as long as without kangaroo. The other thing is the baby also gets immunity faster than the babies who are not done kangaroo, so they are also not getting infections at a higher rate. There is reduction in infections. Yes. For the baby, there is the boarding also with the mother. There is prevention of the infection, I've said. And also there is the lactation. The mother is able to produce more milk at a faster rate. So there is always consistent supply of the milk. So there is no lack of breast milk. And apparently we feed our babies breast milk 100%. Very rarely will you give formula unless there is an indication which must be prescribed by a doctor. We don't just generally give formulas.
In the wake of the ongoing COVID-19 pandemic, infection prevention during kangaroo care remains key in helping keep the baby's health in check.
Apparently, I didn't do kangaroo for my baby because now that's when we had the pandemic of COVID-19. We didn't know how to handle this pandemic, and we didn't want to infect the babies in NICU. So we were not allowed to do kangaroo, and the hospital time that you were allowed to stay with your baby was 1 hour. So we really didn't have that privilege. But yes, after discharge, I used to kangaroo. My mom also used to kangaroo, and my spouse. So we did it after discharge, but not in hospital.
It was quite difficult because of the contact. There was this issue of contact and the baby. But eventually with time we were able to do the kangaroo. We have not stopped, we continued. All we allow the mothers to do when they come in, we allow them to have, we have provided for them a facility for taking a shower. They change into our hospital gowns, and then they come in and we continue with the kangaroo. And they must wear their mask, they must continue their social distancing. Even at our kangaroo room, we must do that. And then we restrict other visitors into the unit.
Premature babies can lead a normal life upon receiving adequate care.
First 3 months were very tough. I remember I had to be readmitted 3 times, and this is because she used to get apneas and stop breathing. So I used to do mouth to mouth, then we rushed to hospital, we get back to NICU again. So it was very tough. Okay, I had to buy like oxygen, I had to buy the to rent the suction machine so that I'm able to give the cares to that baby. So the first 3 months were very tough, and they were very expensive because, you know, like buying oxygen, I used to buy like 10,000 per cylinder. Hiring the suction unit was like 5,000. So it was a very tough journey and very expensive. Yes, but later on, as she matured, the journey was now a bit easy. I can see now she's a big girl. She's now 1 year. She's able to walk. She's been able to meet all the milestones. So the journey at this moment is easier. She's not like any other baby, but the first 3 months were quite hard.
Whereas care of preterm babies is key in ensuring their survival, prevention is always the better solution, and that starts with a healthy pregnancy. Therefore, quality care during pregnancy will ensure the health of both the mother and baby. Gloria Milemo, KTN News.